Welcome back to the topic pharmacological actions of adrenergic drugs. So, to understand the pharmacological action of adrenergic drugs, you need to remember the location of each receptor. So, the adrenergic drugs, the action is mediated via the adrenergic receptors. So, you have alpha receptor and beta receptor, and the drugs have different affinity towards these receptors. So if you see adrenaline has activity or affinity mainly for alpha 1, alpha 2, beta 1 and beta 2, but they have very weak beta 3 action, whereas noradrenaline has no beta 2 action. They have alpha action, that is alpha 1, alpha 2, beta 1 and beta 3. And if you see isoprenaline has no alpha action. It does not act on the alpha receptors. It only acts on the beta receptors. That too beta 1 and beta 2. They have weak beta 3 action. So if you see the effect on each organ, so action of adrenaline. So adrenaline action on the CVS cardiovascular system on the heart. So if you remember, beta 1 receptors are predominantly present in the heart. So adrenaline acts through the beta 1 receptors and they can increase the heart rate, increase the force of contraction, increase cardiac output and increase conduction velocity. So overall they act as a powerful cardiac stimulant. So by increasing all these activity, it can increase the workload of the heart as well as it can increase the oxygen consumption of the heart. And also the myocardium becomes more susceptible to arrhythmia. Let's see the effect of adrenaline on the blood vessels. So effect of adrenaline on blood pressure is complex because they can stimulate both alpha receptors and beta receptors. So by acting on the alpha receptors, especially alpha 1, they produce vasoconstriction, and by acting on the beta 2 receptors, they can produce vasodilatation. So the effect depends upon the drug, its dose and the vascular bed. So in skin and mucous membrane, viscera and renal beds, vasoconstriction is prominently seen because of the action of adrenaline on the alpha 1 receptors, whereas vasodilatation is mainly seen in skeletal muscle vessels, liver and coronaries, that is mediated through the beta 2 receptors. To see the effect of sympathomimetics on the blood pressure, noradrenaline or norepinephrine, it can produce rise in systolic and diastolic BP. So if you remember, it acts on the alpha receptors and beta uh, 1 receptor without much action on the beta 2 receptors. So there is rise in systolic and diastolic BP. With isoprenaline has no alpha action, it only acts on the beta receptors. By acting on the beta 1 receptor, they can produce rise in systolic BP, and by acting on the beta 2 receptor, they can produce fall in diastolic BP. And when the BP rises, what happens? Reflex bradycardia can occur due to stimulation of vagus. So this reflex bradycardia is very prominently seen with noradrenaline. Now, dose-dependent action of adrenaline on blood pressure. So, adrenaline, when it's given as small doses, given by infusion, IV infusion or subcutaneous small doses when you give, they produce fall in BP. That is mainly due to beta 2 mediated vasodilatation in the skeletal muscle. So, skeletal muscle beta 2 action is more prominent. So beta 2 receptors are very sensitive to small dose of adrenaline, and with adrenaline there is increase in systolic BP and with slight decrease in diastolic BP. Okay, so mainly they produce fall in BP when you are giving adrenaline small dose given by IV infusion. So moderate dose when it is given by IV, they can produce rapid rise in BP followed by a fall. So adrenaline, when it's given by IV, moderate dose of adrenaline, they can produce rapid rise in BP followed by fall. That is known as a biphasic response. Okay, so if you see this, Here you can see the rapid rise in BP followed by a fall in BP. Later it comes back to normal. Now why this happens? Biphasic response of adrenaline. So this initial rise in BP is mainly due to alpha 1 mediated vasoconstriction. So you have alpha 1 receptors and also beta 1 receptors in the heart also contribute. So beta 1 mediated increase in heart rate and force of contraction can be seen. So this rise in BP is mainly due to the action on alpha 1 receptors and beta 1 receptors. Now, as the concentration of adrenaline gradually decreases around the alpha receptors, it can continue act on the beta receptor. But here, because the alpha action is masking the beta receptors, that is beta 2 receptors, only the vasoconstriction can be seen. But when the dose decreases, it cannot act on the alpha receptors, but it can continue acting on the beta 2 receptors, because beta 2 receptors are very sensitive to even small dose. So this beta 2 effect, that is fall in BP, persists longer. Okay, so as the alpha effect wears off, beta 2 mediated fall in BP predominates, and later it comes to the normal level. So this is known as biphasic response seen with adrenaline, moderate dose given by IV. So what is biphasic response is rapid rise in BP followed by a fall in BP. So this rapid rise is mainly mediated by action of adrenaline on the alpha 1 receptors and beta 1 receptors, whereas this fall in BP is mainly by action of adrenaline on the beta 2 receptors. Now you have something called as Dale's vasomotor reversal. So you already saw adrenaline produces biphasic response, right? Increase in BP and fall in BP, then it comes back to the normal level. When the alpha receptors are blocked, okay, so after you give a alpha receptor, when you give adrenaline, adrenaline will produce only a fall in BP. Okay, so if you remember, we saw in the last slide, this increase in BP is mainly by action on the alpha 1 mediated vasoconstriction. Okay, so this rise in BP and fall in BP. So here you're giving an alpha blocker. After giving an alpha blocker, you give adrenaline again. Repeat the dose of adrenaline again. What you can see? Only the fall in BP can be seen. The rise in BP is not to be seen. So this rise in BP is not seen because the alpha receptors are mainly blocked by the alpha blocker. You have alpha blocker, we'll be discussing later on. So this alpha blockers can block the alpha receptors, thereby blocking the rise in BP. The only fall in BP can be seen with adrenaline. Okay, so this phenomenon is called as Dale's vasomotor reversal. Action of adrenaline on other vascular beds. On the renal vessel, there will be vasoconstriction which can produce fall in renal blood flow. On the cerebral and coronary circulation, the blood flow is enhanced. And also they can cause cutaneous vasoconstriction. So it can be used along with local anesthetics to prolong the duration of action. Action of adrenaline on the smooth muscles, mainly the lungs. So if you remember, beta 2 receptors are predominantly present in the bronchial smooth muscle. So adrenaline, by acting on the beta 2 receptors, produces bronchodilation. So adrenaline is a powerful bronchodilator. It can also produce mucosal vasoconstriction by acting on the alpha receptors in the bronchi, leading to decongestion. So as a result, it can increase the vital capacity of the lungs. In the uterus, it mainly contracts the non-pregnant uterus, but they can relax the uterus in the last month of pregnancy. So this relaxation or dilatation is again by acting on the beta 2 receptors in the uterus. In the GIT, the smooth muscles of the stomach and the intestine is usually relaxed by action on alpha 2 receptors and beta receptors on the stomach as well as intestine, smooth muscles of stomach and intestine, and the sphincters are constricted. So on the GIT, they produce a very transient and weak effect. Whereas on the bladder, it can relax the detrusor muscle. So you have beta 2 and beta 3 receptors on the detrusor muscle, which is relaxed, and they contract the trigone of the sphincter, okay, by acting on the alpha 1 receptor. So it can hinder micturition or increase the holding capacity of the blood. On the eye, so the radial muscles of the dilator pupillae have alpha receptors, mainly alpha 1. So adrenaline or sympathomimetics adrenergic drugs can act on the alpha 1 receptors on the radial muscles and produce constriction of the pupil leading to mydriasis. So the mydriasis, active mydriasis, because they are producing contraction of the radial muscle, and they can also increase production of the aqueous humor, and thereby they can reduce the intraocular tension, intraocular pressure. So in the eye there is active mydriasis with no cycloplegia. So this is how we can differentiate between adrenaline and atropine on the eye. Atropine on the eye produces mydriasis, which is passive with cycloplegia, whereas adrenergic drugs can produce active mydriasis with no cycloplegia. Effect on the CNS. So on the CNS, they can produce activation of the alpha 2 receptors, mainly the presynaptic alpha 2 receptors in the brain are activated. They can reduce a sympathetic outflow, and they produce fall in BP. Coming to the metabolic effects of sympathomimetics or adrenergic drugs, it can produce glycogenolysis and gluconeogenesis, thereby they can produce hyperglycemia. They produce lipolysis, thereby there is increase in free fatty acids in the adipose tissue. They can reduce the insulin release by mainly action on the alpha 2 in the pancreas. They can increase the BMR and cardiovascular effects, thereby increasing the body temperature. And also there is transient hyperkalemia followed by hypokalemia. On the skeletal muscle, adrenergic drugs or sympathomimetics can facilitate the neuromuscular transmission by mainly acting on the presynaptic alpha receptors. Okay, so thereby they can increase the release of acetylcholine at the neuromuscular junction, which can facilitate the neuromuscular transmission. And they can also produce tremors. So beta receptors are more prominently seen in skeletal muscles than the alpha. Beta 2 receptors are most prominently seen than the alpha receptors. So there will be muscle twitches which will be shorter and more forceful, and there is enhanced firing of the spindle which can lead to tremors. And also, because the beta receptors are more, there will be vasodilatation and more blood flow to the muscles, which has an anti-fatigue effect. With that, we come to the end of the pharmacological actions of sympathomimetics or adrenergic drugs. Thank you for patient listening.